Hi, my name is Daniel Ross, and I am a nephrologist at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. I'm so glad that you'll be joining me today for this talk on Introduction to Lung Ultrasonography for the Nephrologist. This is an area that I feel very strongly and passionately about, and I hope that by the end of this, you will feel just as strongly. The learning objectives for today are that by the end of this talk, you'll know the appropriate lung scanning zones, be able to identify the pleural line, know how to characterize artifacts that arise from the pleural line, and that you'll be able to recognize basic lung pathology. So lung ultrasonography is different from other fields of ultrasound. In other fields of ultrasound, you're using the ultrasound to recreate a real image of a particular organ. In lung ultrasonography, we are actually using the ultrasound to generate artifacts, and we're interpreting those artifacts. So it's a little bit different than what you might be used to in other organs. We need to talk about performing lung ultrasound. How do you do it? And we will talk about selecting the correct probe. I'll give you some of my own tips for image acquisition. And then we'll talk about normal aeration pattern. What does a normal lung look like? Selecting a probe. There are three different types of probes that you need to know about. The first is the vascular probe. This is the linear probe that you are probably familiar with for when you do dialysis catheter placement. The advantages of this probe is that it's a high frequency probe, and it will give you really excellent high resolution images of a superficial structure. However, because it's a high frequency probe, there's a lot of attenuation that happens, and so you can't really see deep structures very well. So the obvious disadvantages are that you can't visualize the heart or the kidneys very well, but it's great for the pleural line, which we'll talk about. The curvilinear probe is what many nephrologists will be familiar with. This is the probe that we use for kidney biopsies and for ultrasound. It's wide and it has a large footprint, and so you can actually view multiple rib interspaces at once. And it's great because you can also view the kidneys. So if you're doing a full renal focused ultrasound examination where you want to look at the lungs, the IVC, the kidneys, the bladder, this is a great probe for that. The disadvantage is that it's not as good for really picking up fine subtleties in the pleural line like the vascular probe is. The cardiac or the phased array probe is similar. One of its big advantages is that you can see the heart. It has a small footprint, and so it can squeeze nicely in between your rib interspaces. And the disadvantage is that, again, it's not great for looking at the pleura. Going on with my tips for image acquisition. Identifying lung scanning zones. So you want to scan at least 8 zones. And you can see here, this is an image from the International Consensus Guidelines on Lung Ultrasound, and it shows you the standard 4 regions that we would scan on the right, and then you can imagine the same image on the left. When you can't get an answer from some of your anterior zones, you really need to make sure that you're aware of the PLAPS point, which is the posterior and or alveolar or pleural syndrome point. And this is roughly the 5th intercostal space, but you're going to be putting your knuckles to the bed and trying to get as posteriorly as you can, sometimes in the mid-axillary, but really more towards the posterior axillary line, because that's going to be a high yield spot for identifying lower lobe consolidations and pleural effusions. How many different spaces should you scan? Well, there's debate about that, and it depends on who you ask. Generally, by international consensus, 8 zones is at least recommended. However, if you're in a hyperacute emergency, it's reasonable to use just 2 zones in a really emergent situation. there is a tremendous amount of research into lung ultrasonography where researchers have quantified and qualified ultrasound findings looking at 28 intercostal spaces. Now, a common question I get, well, that seems laborious, and how long could that possibly take? Well, the truth is it doesn't take that long to do a full 28-point examination. It usually takes anywhere between 6 minutes for someone who's experienced, maybe 15 minutes for someone who's less experienced. But you can imagine that an 8-zone will take even less than that. When you're learning a new skill, you really need to take your time. If you're not comfortable, you're going to find yourself less likely to really commit to learning ultrasound. If you are bending over the bed and your back starts to ache, you're going to say, I'll just grab my stethoscope. But if you make yourself comfortable, you'll feel more inclined to sit and spend the time that is needed, which is why I always recommend making sure that you're comfortable before you start sonoing a patient. You want to make sure that the bed is elevated so that you're not hurting your back. You want to make sure that you have a chair if possible. You want to make sure that you have a lot of battery life left in your ultrasound. You want to make sure that you have plenty of gel available. You'll place the indicator of your probe cephalad towards the patient's head. And don't press too hard. Now, the biggest pitfall that I've noticed in novice learners is that they can't quite get the image correct. And my tip for this is you have to remember that in order to image the lungs appropriately, you need to hit the pleural line at a 90-degree angle. And the pleura curves over the surface of the lung. So sometimes it takes a little shimmy to the right, to the left, cephalad or caudal, just a little bit to get that ultrasound beam to hit the pleural surface exactly at that perpendicular angle. Adjust the depth so that the pleural line is in the center of the view field, where you'll have a high resolution and you can look for irregularities. You can make the depth deeper, but I wouldn't recommend going past 12 centimeters. You want to adjust the gain on the ultrasound down sufficiently so that the rib shadows are nice and black. Characterizing the pleural line is essential to accurately interpreting lung ultrasound. So you want to look at that pleural line, and if there are questions about it, change your probe from your abdominal or phased array probe to your vascular probe, and use that to really characterize what's happening at the pleural surface. So I've described tips for how to acquire the image. Now let's talk about what you should see in a normal lung, what I'm calling normal aeration pattern. You're going to see the bat sign. This is the bat sign. Rib and a shadow beneath it. The pleural line. And then your first A line. We're going to take the idea of the first A line and we're going to pocket it for now. We're going to put it in the back of our heads. We're going to come back to it later. There's our bat. You see wing, wing, head. Lung sliding is one of the most important aspects of a normal lung ultrasound. The visceral and the parietal pleura rub together during the respiratory cycle. And in a normal ultrasound, that will appear like a glistening or gliding at the pleural line. Some people have called it ants marching on a string. If you want to confirm the presence of lung sliding, you'll put the M mode through the pleural line, and since it's continuously moving underneath that line, it will have a hazy sand-like appearance, and it looks like a beach with sand and then an ocean in the distance. And I'll show you a picture of that in a minute. Now, if there is no motion underneath the pleural line, then you will see in the M mode just another straight line, and it will look like streaks. And some people call this the barcode sign or the stratosphere sign. So let's take a look. Of note, lung sliding is absent, so you'll see the stratosphere sign in pneumothorax, possibly pneumonia, ARDS, and interstitial lung disease. The presence of lung sliding at an interspace rules out a diagnosis of pneumothorax. It makes sense. In a pneumothorax, the visceral and the parietal pleura are separated, so you will not see lung sliding. And studies have showed that the presence of lung sliding rules out pneumothorax at that interspace with nearly 100% sensitivity. Here's a classic example of lung sliding. Now, if you were to place an M mode right through here, you would see this continuous motion here that would appear as a sandy beach. And here we are. This is the seashore sign. And this confirms that the visceral and the parietal pleura are interfacing. As opposed to absent lung sliding. So here we see that the only motion is attributable to these respiratory muscles that are trying to move, but the pleural line itself is static. And so when we throw the M mode through that, we see the barcode sign or the stratosphere sign. Now, we have to move on to talking about interpreting the artifacts that arise from the pleural surface. And the central theme here is that acoustic impedance, when it differs between two substances, the ultrasound wave will be reflected. And so when an ultrasound wave hits the underlying air, there's a huge difference in acoustic impedance between the tissue and air. And so the ultrasound wave goes back to the probe, reverberates, and comes back. And it makes the machine think that there is another pleural line deep to the pleural line. That's called your first A line. So we're going to talk about defining A lines, defining and quantifying B lines, and then we'll move on to talk about other lung pathologies such as pleural effusions and consolidations. So I believe that repetition is very important for learning. So I laid the groundwork talking about differences in acoustic impedance, and so here it is again. The ultrasound wave leaves the probe. When it moves from tissue into air, it gets pushed back to the probe and then goes back again. And so you see A lines. So here is the pleural surface. Here is your first A line, your second A line, and your third A line down here. This indicates normal aeration. Normal aeration. And I'm going to show you some data now to help you understand what that means. This is a seminal study published in 2009 by Dr. Lichtenstein, who is considered to be one of the fathers of lung ultrasound. Patients were taken for right heart catheterization, or they had a Swan-Ganz catheter, and lung ultrasound was performed. And what this shows is that most patients with A-line pattern, meaning a normal aeration pattern, had a wedge that was less than 13. That kind of makes sense. So if there are A lines, there have to be B lines. So I want to reset for a minute before we go on to talk about B lines. We'll go into a little bit of cardiovascular hemodynamics. So if the left ventricular end diastolic filling pressure is high, then the left atrial pressure is high, and then the pressure in the postpulmonary capillary bed is high. And because of Starling's law, the sum of the hydrostatic and oncotic pressures, water will move into the lung interstitium and fill interlobular septa. And you'll have extravascular lung water. So a high pulmonary wedge pressure means you'll have filling pressures from the lung capillaries down to the LV. And a high wedge pressure is going to give you, by extension of that, extravascular lung water and water that accumulates in the interlobular septa. Now, if an ultrasound wave meets a water-thickened interlobular septa, there is a difference between fluid and air. And so the ultrasound waves will reverberate back to the probe, and the probe will think that there's a continuous structure deep to the pleural line. And here is a picture of what that looks like. So these are B lines. Now, it is incredibly important that when you are starting out in the practice of interpreting lung ultrasonography, that you know the criteria for defining a B line. Because if it doesn't meet these criteria, then it's not a B line, and you're going to be misinterpreting what you see. B lines arise from the pleural surface. They're hyperechoic. They're well-defined and laser-like. They're long, and they spread out without fading. They move as the lung slides, and they obliterate A lines. They have to, because A lines are a normal aerated lung, and these are abnormally aerated lungs. What's fascinating is that when you look at what are called septal B lines, Lichtenstein has shown that CAT scan correlates with ultrasound findings, that the water-thickened interlobular septa in the CAT scan correspond to the lung ultrasound at the same interspace in that same patient. And they're usually about 7 millimeters apart. Further building on the evidence of what B lines are, because some might argue that they're an artifact and apply no meaning to them, as your wedge pressure increases, the number of B lines increases. In the old nomenclature, a Comet score is simply counting the number of B lines that you would see throughout the patient's lung. The number of B lines, the Comet score, now known as the B line score, is also correlated directly with extravascular lung water. And there are multiple studies that have been repeated and showed this relationship a number of times. The data that lung ultrasound and B line number correlates with extravascular lung water and wedge pressure, that data abounds. What I want to make note of here is clinically relevant. Look at the scatter along the lines. You'll notice that with 10 B lines, for instance, you might have a wedge of 10 or a wedge of 30. So there is variability here, and I want novice practitioners to know and appreciate that. It's not a simple mathematical equation of y equals mx plus b, that 10 B lines equals a wedge of 20. There is a significant amount of variation between this. And so you have to interpret with a grain of salt, and clinical correlation is definitely required. Defining the relevance of these B lines, I'm going to move now into talking about dialysis patients, and I'm going to talk to you about the literature, and then I'm going to make a very different discussion about clinical practice. So let's talk about the literature. This was a very important study done by Dr. Vicky Noble, and this was a study of 40 dialysis patients who were in the inpatient setting who had sequential lung ultrasound performed. And what it showed was that B lines disappeared rather they were reduced in all instances. Now, if B lines didn't represent anything and they were just artifacts with no meaning, then you would expect that pre and post dialysis, some would go up, some would go down, some would stay the same. Now, it's true that some of these patients had no B lines to begin with, but of the patients that did have B lines, with ultrafiltration and volume removal, that number was reduced in all patients that they looked at. And furthermore, when available, patients who had an echocardiogram, they showed a relationship between lower ejection fraction and a higher number of B lines. So this was really interesting information, a proof of concept, if you will, coming from the dialysis patient population. Another study was done looking at the number of lung comets in dialysis patients in Italy, looking at left ventricular ejection fraction. The more lung comets you have, the lower your ejection fraction. The left atrial volume, lung comets, and pulmonary artery pressure and lung comets. This is all data from dialysis patients, all showing that the number of B lines correlate with echocardiographic parameters of filling pressure. Now, we had looked at the literature available on this, and at the time that we published, there was 12 meaningful studies. And one of the things that we noticed throughout the literature is that in dialysis patients, lung ultrasonography correlates with congestion, with New York Heart Association class. Out of the 1, 2, 3, 4 studies that were done, 3 of them reached statistical significance, showing that as you had more congestion, your New York Heart Association class was higher. So again, more evidence from the dialysis population that this is meaningful. I'll add that the lung ultrasound in each of these studies was done by a full 28-point lung ultrasound. One of the most important studies was done in Italy by Dr. Zoccali. And you could say that B lines correlate with volume status, but why care? Does it mean something? And in their cohort, they looked at 392 patients, and they categorized patients as mild, moderate, or severe lung congestion based upon the number of B lines that they counted in these patients. They looked at the patients for about 2 years, and they found that when comparing those with mild to severe congestion, you were at a 4.2 times increased risk of death if you had lung congestion. And there was a reclassification index that they did, and it did show significant results there as well. What was interesting to me was that 70% of the patients with moderate to severe congestion were asymptomatic. And many of you will have seen these patients before in your dialysis practice. These are the patients that come in who gain 5 kilograms and seem to be doing just fine with it, but somehow you know that the fluid is hiding somewhere, and if you were to ultrasound their lungs, I'm sure that they would have severe congestion. So we talked about defining B lines and their relevance in the literature that comes from dialysis populations. I want to talk a little bit about how this differs in clinical practice. I was very steeped in the literature, and I had a disagreement with one of my critical care colleagues who I had sonoed the patient's lungs, and I had seen some septal B lines, and the patient was incredibly short of breath. And the pulmonologist said to me, well, yes, I understand that the patient has B lines bilaterally with a normal pleura. However, I don't believe that those B lines that you're showing me are accounting for this degree of dyspnea. And sure enough, his argument was that the patient was short of breath because of his ileus that was pressing up on his lungs and his diaphragm. And the patient's dyspnea got better with an NG tube, not diuresis. And so I make that point because the question that you have to ask yourself is, is what I'm finding in my acutely dyspneic dialysis patient explain this patient's dyspnea? You're going to ask yourself, what pattern do you see? What is the overall pattern that you see when you're sonoing the patient's lungs? Now, to be clear, it's unlikely that you're doing a 28-point lung ultrasound and counting the number of beat lines. You are most likely in clinical practice going to be doing an 8-point ultrasound and categorizing the patient's lung pathology qualitatively, not quantitatively. So is this A-line pattern? Does the patient have A-lines bilaterally with a sliding pleura, aka a normal aeration pattern? Your dialysis patient who just comes from dialysis after 3 kilograms of ultrafiltration comes in acutely short of breath and has A-line pattern bilaterally with normal lung sliding. You're not going to be thinking more that this patient needs ultrafiltration. You're going to be thinking more that this patient might have a pulmonary embolism, a COPD exacerbation, or an asthma exacerbation. Or does your patient have B-line pattern? And let's be clear about what B-line pattern is. Now, remember before, for research purposes, we were talking about quantifying the number of B-lines at 28 intercostal sites. Now, clinically, what's more common is that you'll do an 8-point at least lung ultrasound, and you'll get a sense, and you'll qualitatively describe, are there 3 or more B-lines at a given intercostal space on the left-hand side and on the right-hand side? If there are, that's called B-line pattern. And B-line pattern indicates an interstitial syndrome. Interstitial syndrome, NOS. Well, what could it be? That could be pulmonary edema in the appropriate clinical setting. It could be pneumonia, pneumonitis, pulmonary fibrosis. And so clinical correlation is required. With that, I want to talk about some of the subtleties of identifying pulmonary edema. So yes, technically, if you have a positive region here and a positive region here, but all other regions are A-lines, that technically is B-line pattern by definition. But that's very unlikely to be pulmonary edema. Pulmonary edema is a diffuse process. You will usually see it where it's equally distributed, not only throughout both hemithoraces, but also within a given interspace. You will usually see this regularly spaced B-lines with a very clean, straight pleural surface. If you see 3 B-lines clustered to one side of the interspace, technically, yes, but in reality, no. That's not going to be pulmonary edema. And there's a continuum here. And this is something that I developed an appreciation for later on, and this is what that pulmonary attending was talking about. What I had seen in the patient was septal B-lines of pulmonary edema. And that's the water-thickened interlobular septa. It has not progressed to the point of alveolar edema, which would be more of a whiteout pattern. So that patient who was extremely short of breath acutely, it didn't correlate. So septal edema usually appears first. 7 millimeter separation usually corresponds to about 3 B-lines in an interspace or more. And then ground glass, which is going to be even smaller spaces between B-lines, that can be up to maybe like 9 or so. And then whiteout, where the whole interspace just appears like one big B-line. It's snowed out. This is the Birulot variant. And I will make note that in clinical studies where they encountered a whiteout pattern or confluent B-lines, they counted those as 10. So for those studies that I showed you, that was the common practice, was to count those regions as 10 B-lines. So if you are a nephrologist examining a patient with a stethoscope, you need to be aware of more things than just rails. You went to medical school, and so you need to be able to identify other etiologies of dyspnea. And so I'm going to talk about that now. So a pneumothorax, we discussed this already. You will see A lines, but there will be no lung sliding. You need to know how to recognize that, because if you have a patient who's coming in from your dialysis unit, acutely short of breath, and they have tracheal deviation and absent lung sounds, you need to know what that means and how to proceed appropriately. That patient doesn't need ultrafiltration. That patient needs a chest tube. Obstructive lung disease, so COPD, asthma. A lines will be present. The pleura may or may not be irregular, depending on the degree of parenchymal involvement. You need to be able to identify a pleural effusion, and you need to be able to identify consolidation. Let's talk about pleural effusion. Pleural effusions accumulate in dependent areas, and this is why I referenced earlier the PLAPS point. The PLAPS point, the further posteriorly you go, the more likely you will be to find what you're looking for. So you want to look at least the mid-axillary line and possibly even more posteriorly. There is the quad sign, and the four boundaries of the pleural effusion include the pleural line. Here, in this case, it'll be representing the parietal pleura, two rib shadows, and then the surface of the lung, which in that case will be the visceral pleura, and then whatever's underneath it. Oftentimes there could be lung rockets and B-lines underneath it. And just a note that if you're seeing lung with a surrounding pleural effusion, if that lung is aerated, it's going to appear to be floating on top of the water, as opposed to a consolidated lung. That lung is going to appear to be more floating in the water. It's physics. So here's the quad sign. You could see a rib shadow and a rib shadow, and you could see this is called the lung line, which is also corresponding here to the visceral pleura, and then the pleural line here, which in this case is the parietal pleura. This is a large effusion. So you could see here, this is the diaphragm. This is the liver. Here is part of the lung. I really like this image because it shows a couple of things. It shows the liver. It shows the diaphragm. It shows a little bit of a pleural effusion here, and you see the actual parenchyma of the lung inside of it. And you see something known as the curtain sign, that as the patient's breathing, the normal lung is coming over the diaphragm. So you see it here. That's the curtain sign. It also shows the spine sign. And why is that interesting? It's interesting because if you are ultrasounding someone's lungs, you shouldn't be able to see the spine because the air will occlude it. However, if there is fluid there through which the ultrasound wave will travel, then it will hit a vertebra, be sent back, and there will be a corresponding shadow behind it. So here you actually see the outline of the patient's vertebrae. Let's review. Liver, a little pleural effusion. The spine sign was here, and the parenchyma of the lung is over here. Great. Now we'll talk about identifying consolidation. There's the shred sign, subpleural consolidations, irregular pleura, hepatization, and we have to talk about and finish up with air bronchograms. Shred sign. So in a non-translobar consolidation, the affected area is going to have irregular borders. So you can imagine a healthy lung, and there is a consolidation right in there that doesn't take up the whole lung. The border between the healthy and the non-healthy is going to be irregular. It's not going to be like an abscess where it's circular or something like that. It'll be irregular and it'll look shredded. And so here we have the shred sign. So we have a rib shadow here. We have a pleural line there, and we have the shred sign there. And this is consistent with consolidation. And then you're going to get a subpleural consolidation. And having come from the epicenter of the initial wave of COVID-19 in the United States in New York, I can tell you that I saw a lot of subpleural consolidations because that was everywhere. And in fact, this does come from a patient with COVID-19. So we have rib shadows here, the pleural line, and a subpleural consolidation. You could see that there are these lung rockets coming out from underneath it. And so don't be fooled and interpret this as pulmonary edema and say this patient needs volume removed. This is not that type of lung rocket. Sometimes you just get an irregular pleura with these B lines coming from it. So you have to recognize that in pulmonary edema, the pleural line is going to be straight and smooth. Here you can clearly see that not only is the pleural line lumpy and bumpy, but it's also fractured in places, and coming out of those fractures are these lung rocket B lines. And so those, again, you're going to look at that and you're not going to say this is pulmonary edema, ultrafiltration required. You're going to say maybe something else is going on. Hepatization. So the term comes from liver. Looks like the liver. When you have a densely consolidated lung, the echogenicity becomes similar to liver, and that's what you see here. So here is the patient's diaphragm, and there's liver underneath right over there, and this is actually lung, not liver. And you actually do see, because this is a dependent area, you do see the beginnings of a spine sign here. So if you have air with surrounding fluid, you'll get an air bronchogram. And if you have a pneumonia, as the patient breathes, those bronchograms will be dynamic. And that's an important thing to remember. So we have here, we have dynamic air bronchograms. So as the patient is breathing, you're seeing signs that are consistent with pneumonia. As opposed to here, where you can't really tell, you're not really sure it could be atelectasis, there's no air bronchograms here. And this is also, this is atelectasis. There are no mobile air bronchograms. So we covered a lot of ground, and I hope that you enjoyed this talk and found it educational. I want to revisit the learning objectives that we spoke about, and let's see if we met them. We said that by the end of this talk that learners would know the appropriate lung scanning zones. So we reviewed 8 lung scanning zones, how to obtain those images. We talked about the importance of identifying the pleural line and determining its integrity. Is it straight? Is it sliding? Is it lumpy, bumpy? Is there a subpleural consolidation? And then we talked about how to characterize the artifacts that arise from the pleural line. Are they A lines or are they B lines? And what does that mean? And we finished up by talking about basic lung pathology, how to identify a pleural effusion, how to identify a consolidation. And with that, I would like to say thank you, and I hope you enjoyed my talk. I want to make some acknowledgments. Dr. Paul Mayo and Mangala Narasimhan, who were critical care faculty at our institution. All images were from either from the cited literature, but most of them were either ones that I took or by my colleagues that they graciously shared. I'd also like to thank Dr. Fishbane and Dr. Javeri, who have been my mentors in the Division of Nephrology, who have given unwavering support in my pursuit of learning and teaching lung ultrasound. And all of my references are here. Thank you. Goodbye.